moving on to our next group of presenters. Our next presenters join us virtually from Seattle, Washington, where they work as physicians and as faculty teaching our next generation of physicians. Dr. Casey Lyon serves as an attending physician in general pediatrics at the University of Washington Medical Center and is an associate professor in the Department of Pediatrics at the University of Washington School of Medicine. She's an investigator at the Seattle Children's Research Institute, co-director of the Health Services and Quality of Care Research Fellowship, and program lead for patient navigation for the University of Washington Cancer Consortium's Office of Community Outreach and Engagement. Dr. Lyon is joined by Dr. Emily Hartford, who is an assistant professor in pediatric emergency medicine at the University of Washington. She also works in the emergency department at Seattle Children's. Dr. Hartford teaches trainees and works on improving care equity and language access for patients in the ED. Dr. Hartford is also on the faculty for the Pediatric Emergency and Critical Care Fellowship in Kenya at the University of Nairobi and works with the African Federation of Emergency Medicine on educational tools to improve care for sick children globally. Both these speakers have extensive clinical experience integrating tools for language access. They know intimately where the gaps are in our systems and how far we still have to go. They will focus us on both the individual actions we need to take and the ways we can champion change. Please welcome them both.
Thank you so much for that lovely introduction. Let me share my slides. All right. And if you are not seeing the slides in the view you would expect, please let me know. All right, well, we are so delighted to be here speaking today. And Emily and I are going to be speaking about language equity in clinical encounters. I'm going to get us started and then we'll switch off to Dr. Hartford partway through. So I wanted to begin by sharing that neither of us have anything to disclose, and then walk us through some objectives for this talk today. So by the end of the next 50 minutes or so, we hope you will each be able to critically evaluate your own communication practices, both through self-reflection and through stratified data to recognize ways you may be contributing to disparities. Be able to implement changes to how you communicate with patients and families who use a language other than English for medical care. And explore strategies to navigate challenging situations when communicating across languages. And also, we're both pediatricians, so you will often hear me talking about communicating with families, but if you are not a pediatrician, please substitute in patient as appropriate. Before I move any farther, I want to start by just reflecting on the fact that good communication is hard, even when you think you've been very clear about what you mean, right? As evidenced by this comic here. And I think we can probably all think of instances where we thought we had been very clear about something and we were misunderstood, or we misunderstood someone else, right? And this is true in both our personal lives and our professional lives. And so really, sorry, to take a step back, I'm going to frame by, before we talk about interpreter use and how to communicate well through an interpreter, we really want to spend a little time talking about communication, because that is the thing that needs to be optimized in order to achieve good communication in a multilingual setting. So what is good communication? According to the literature, good communication is comprehensive and bidirectional. It encourages full engagement of everyone involved. It is oriented around problem solving. And it is supportive, reassuring, and ultimately achieves a shared understanding. And the thing to note here is that each one of these elements is independently associated across different studies with better outcomes. So it's not just that somebody who does all of these things gets better outcomes, better clinical outcomes compared to someone who does none of these things. Every one of these has been found by itself to be associated with better patient outcomes. So one example from a study conducted by Thomas and colleagues, the communication intervention was as simple as telling a patient who had an unclear diagnosis that they actually had a diagnosis and they would get better, which resulted in much greater recovery rates at 2 weeks out compared to the control group, who were told just that there was an uncertain diagnosis and they weren't really sure what was going on. And so while I'm not sure I would advocate lying to patients, the study really highlights the power of reassurance specifically and communication more generally to change patient outcomes in ways that really make a difference for patients and families. And so you may be wondering, what sorts of outcomes does communication impact? And it is not just the obvious ones like satisfaction, comprehension, and adherence to recommended care, although good communication certainly affects those things, but it's also much, quote unquote, harder clinical outcomes, including things like the patient's functional status, in-hospital opioid use, glycemic control in patients with diabetes, blood pressure control in patients with hypertension, and symptom resolution in patients with chronic headaches and chronic abdominal pain. And we know that when there are barriers to good communication, we very clearly see worse outcomes. And so these include things like worse access to primary care and subspecialty care, worse interpersonal experiences, including lower trust, less adherence to recommended care, and lower comprehension. Worse patterns of healthcare utilization, including higher costs of care, longer ED and hospital stays. And worse clinical outcomes, including things like higher risk of perforated appendicitis, higher risk of going with untreated pain, and higher rates of adverse events and missed diagnoses. It's also important to recognize that barriers to good communication tend to be additive, right? And so a patient or family who use a language other than English for medical care, for example, may also have other things that impact the likelihood of receiving good communication in a clinical setting. And these may include things like levels of literacy or health literacy, cultural factors that may influence the way communication happens, either from the clinician or from their end, bias and racism within the medical encounter, both in the current encounter and in previous encounters, and power differentials that impact the way communication plays out and the way they interface with the healthcare system overall. And the thing to recognize is that these barriers to high quality communication tend to aggregate together and disproportionately impact those who are already impacted by structural racism. And so at this point, you might be saying, okay, sure, I'm on board, but I already provide the same high quality care and communication to all of my patients. Aren't I doing enough? And my response to that would be a topic that I think probably many of you are familiar with or have heard about at this point, which is the difference between equality and equity. And equality is where everyone gets the same thing, regardless of whether it's needed or right for them. But I deliver the same high quality communication to everybody and I do my thing. That's equality, right? Whereas equity is everyone gets what they need, understanding their baseline barriers, circumstances, and conditions. So what I deliver to them, what I deliver to different patients and families is not, in fact, the same, but is carefully tailored to an understanding of what it is that they need to get to that similar equitable outcome that looks like the outcomes that we're hoping for everybody. The other thing I would say is that you are in fact likely not communicating the same with all of your patients. So there's actually a fair amount of research based on audio and video recorded clinical encounters to suggest that provider communication depends a lot on patient communication, and that there's a lot of variability within provider in how they communicate based on what the patient or family are doing. And most of these studies are with providers, but we can easily imagine that this extends to other healthcare professionals and all the other members of the healthcare team, right? That it's not that there are some providers who are just like really exceptional communicators and they're exceptional every single time, and there are others who are lousy and are always lousy, but instead that most of us sometimes do a really great job and sometimes do a much less great job. And a lot of that is sort of part of a cycle with whatever the patient and family are doing. And I'd like to take a moment here to pause to let you all think about, to what extent do you feel like that is true for you? And I'm going to walk you through what the actual studies show about how this sort of plays out. And this is based on a number of studies of, as I mentioned, audio and video recorded clinical encounters. And the outcomes for these studies tended to be objectively coded better communication. And so this was communication that was more patient-centered, shared more information, included more supportive statements, among other things. And I just want to remind you that, as we just discussed, better communication is solidly linked to better clinical outcomes. So that's actually what we're talking about here. Right. And so what did they find in terms of like what's associated with better communication? Well, one of the things that has come out in these studies is that patients who are perceived to be quote unquote easier patients or easier families tend to receive better communication from providers. And these are patients and families who are perceived to be more positive, more engaged, more satisfied with the care they're receiving, more likely to adhere, and less contentious. Another thing that's come out in these studies is that patient or parent expressiveness is really associated with the quality of communication that the provider delivers. So this includes the extent to how assertive the patient or parent is, the extent to which they voice their anxieties and ask questions within the clinical encounter. On the positive side, these studies find that partnership building, so explicit steps taken by the provider to build partnership, were associated with increased expressiveness in patients or parents. And this includes providers explicitly eliciting questions and really taking concrete steps to encourage engagement. And unfortunately, both being seen as an easier patient and being more expressive in the clinical encounter have been associated with sociodemographic characteristics like race, ethnicity, culture, and education. And I want to note here that race and ethnicity do not make someone an easier or harder patient, but instead racism and discrimination may make us perceive someone as easier or harder, and previous experiences of racism and discrimination will affect how a patient or parent interacts in subsequent visits, including perhaps being less expressive, feeling less able to voice their anxieties, and perhaps seeming less engaged or less satisfied. So what does this mean, right? So like, okay, this is the summary of what these studies show. How do we put this together? Through this bolded pathway that I've highlighted, from demographics to better communication, which we know is linked to better outcomes, you can see that communication is an important mechanism by which disparities are created and propagated in clinical settings, as members of groups that already have greater barriers to accessing care are less likely to then be perceived or be comfortable behaving in ways that then elicit good communication from us, right? And it's also really important to notice here that families with language barriers that aren't fully addressed with adequate professional interpreting may not have the opportunity to elicit good communication from providers, right? They may not be given a voice in the clinical encounter in a way that will let them demonstrate the expressiveness that will elicit that good communication from us, which will also contribute to or create disparities in outcomes. And then I also want to sort of restate and really emphasize that this piece here of the being perceived as to be an easier patient, right? The ways that we perceive patients and families are informed by bias, racism, and stereotypes, not because we're bad people, but because we live in a society and we live in a society that is really grounded in a lot of bias, racism, and stereotypes, right? And it's also important to recognize that those families' previous interactions with healthcare, which were also informed by stereotypes and bias, influence how they behave and then how we perceive them. So it's essential that we really pay attention to how we're thinking about and reacting to families in the moment as a really crucial step to decreasing the importance of this pathway for creating disparities. It's also really important because we aren't doing this on purpose, right? It's really important that we track our outcomes by race, ethnicity, language, and insurance at a minimum to look for places where disparities exist so that we can really hone in on what's going on, right? Again, because no, we're not doing this on purpose, but it is endemic, right? And we all have biases and we all have stereotypes. And so it's really important to recognize the ways that these may be influencing our communication and then intentionally looking for it, because if we don't look, we won't know. On the sort of happier side, right, we can take concrete steps to elicit engagement in order to mitigate some of these disparities that might otherwise come out in our communication, right? And so this pathway across the bottom from partnership building to expressiveness to better communication to better outcomes is really a concrete place we can focus our attention in thinking about how do we use communication as a tool to reduce disparities, right? And so some of the concrete steps we can really take to increase caregiver expressiveness include using things like teach back, right? And so this is when you, after explaining something that may be complicated, right, try to actually figure out how well you explained it. And so you want to use language like, I want to make sure I explain that well. Could you let me know how you'll take that medication at home, right? It's not about whether the patient understood you. It's really about how effectively did you communicate your ideas. Using open-ended questions rather than closed-ended questions. So what questions do you have rather than do you have any questions? And using normalizing statements. So sometimes when, a patient or family may not be saying very much, and that can make it hard to know what supportive information to provide or what additional teaching to sort of launch into, right? Or what their concerns might be. And so sometimes it can be really helpful to include things like, a lot of people are worried about starting a medication in their child. Is that something that concerns you? Or sometimes parents are worried about, and then include some of the things that you could imagine being worried about or that you've heard other parents be worried about, to try to sort of kickstart the discussion and draw the parent out. Formal communication coaching is another technique that can be really effective. And this is when someone who is typically not a doctor or a nurse spends some time with a patient or family before a clinical discussion, helping them really identify what their questions or concerns are, and then even practice asking them. Those sorts of interventions have actually been associated with much more frequent question asking and sort of concern voicing in patients, which then elicits much better communication from providers. And these have been studied across lots of different clinical settings and are a nice thing to sort of think about trying to find ways to integrate into your clinic or hospital flow. So I want to wrap up my section here by summarizing some of these key points about communication before Emily talks more explicitly about partnering effectively with interpreters. So what are some of these key points about how communication affects healthcare equity? So we know good communication is associated with improved clinical outcomes and that providers communicate differently with patients and families based on their behaviors and characteristics. And through that pathway, communication is a really key mechanism by which disparities are created and propagated, but then also a key mechanism by which we can reduce disparities if we really do the work to break some of those disparity creating pathways and to bolster the disparity mitigating pathways. And so awareness of our own biases, taking concrete steps to encourage communication engagement, and tracking stratified outcomes are really key to identifying and mitigating disparities. And with that, I am going to stop sharing and we'll transition over to Dr. Hartford.
Thank you, Casey. Hi, everybody. Wonderful to be with you today. I'm going to talk a little more about specifically the use of interpreters and interacting with families using an interpreter. I wanted to start just with a question, and this is a long time on Zoom. So if you could just answer in the chat, in the setting where you are working, do you feel you reliably know what language for care is for your patient? Do you know when you're walking into the room or encountering them, however you may, do you know what language is preferred or what they would like to speak in the medical setting? If you could just take a minute and see. Great. Yeah, I see a lot of no's, which not always and many times no. Some people are saying yes. Okay, great. So we're going to talk a little bit more about some of the challenges of providing medical care in the language that families want to use. And in terms of speaking of good communication, the first question is who, quote unquote, needs interpretation? Seems like it should be a pretty straightforward question, but it actually can be quite challenging to determine, and it takes a bit of work. You may have heard the term limited English proficiency, and it's used a lot to describe patients who use other languages than English for care. But most medical settings that I've been in, and I think you will probably agree, do not assess proficiency. There is no English proficiency test saying that someone has limited English proficiency. It's just they're asked or they mention a language other than English, and we put that in the chart. In some settings, you may have asked, what is your preferred language, as a sort of, a nicer way to encounter this with families. But even that can be a misnomer, because if it is the language they wish to use, that they use for medical care, it's not really a preference. It's just the way that we need to be communicating with them to make sure that we have good communication. Language preference also does not correlate perfectly with comprehension. There have been studies where they ask that question, your preferred language, and then they do comprehension and proficiency testing, and it's just not a perfect correlation. So it's important to know that just asking what is your preferred language might not get at it either. I can tell you how we have arrived at doing it in our emergency department, and I don't know if this is perfect or the right way, but something for you to consider. And we use a two-step question for anyone who comes into the emergency department. The first question that they ask is, what is your language for care today? If they state a non-English language, we have a video interpreter unit and a phone interpreter unit right there to call up and then ask, can we provide interpretation? And so we try to do this double check step so that people may answer one language, but then they might say, oh, actually, I don't want interpretation. I just also speak that language. You can kind of, double check yourself. What is your language for care? And then can we provide interpretation? So defining language for care, some challenges that come up frequently that I'm sure many of us have experienced is that different caregivers have different needs. So if you've got multiple family members in the room, the patient and any of their family members might just speak different languages or have different levels of proficiency in those languages. Language needs can also change over time. So you have a family who in your EMR system says they have one language for care, but 5 years later, it's actually different. They want to speak English. They don't want interpretation. And I think the theme here is trying to balance the power dynamic with an empowering dynamic. So rather than the medical providers always sort of being the ones who are in charge of deciding what language is spoken and providing or not providing interpretation, we want families to be more empowered so that they can say when they want to speak, what language they want to speak, and we can provide good communication and care in that language. Just as a note, we use in our setting, and this is something that is changing across the country, and I don't think there is total consensus yet, but we use language other than English for medical care when we're sort of categorizing families who use other languages. OMESA to replace limited English proficiency. So interpretation is commonly underutilized in clinical settings. Most studies that have evaluated this are somewhere between 40 to 60% of the time for families who use languages other than English, do they get any interpretation during their medical care? So we have a lot of room to improve here in all of our settings. What should we be doing? What's the ideal here? We need to screen patients and caregivers at every interaction to ask them what language they want to speak. And we really need to be mindful of consistent use of professional interpretation. It will improve their quality of care and it will improve their patient outcomes. It's a rare example of what we already know what to do to address one disparity. Sometimes we're stuck not knowing what we can do, but this is something we can do right now. There are many modalities for professional interpretation that you probably have experienced. There's in-person interpreters right by your side. Of course, there's bilingual providers with language concordance, which is wonderful when it can occur and when those providers can be certified in their language. And there's remote options like video or phone. And the main takeaway here is that all types of professional interpretation are going to improve patient outcomes. There's some studies showing that providers prefer in-person interpreters. There's some studies about differences between bilingual providers or video, that there being better discharge diagnosis comprehension with videos. But I think the main thing for us to know is there are many ways to do it, but what we want is professional interpretation for every interaction with patients. You may not know, or you may, that providing interpretation in our medical settings has actually been lost since 1964. It's part of the Civil Rights Act that if you receive federal funding, you must require provision of language services in a language that a family understands. The enforcement of this is variable though, and it is an unfunded mandate. So while it's required, there's no funding for it. And so organizations are left to sort of figure that out themselves. And I think we see in practice that this often means we have interpreter services which are underfunded or don't quite have the resources that are ideal. I want to speak now to a few of the risks of not using professional interpretation in our interactions. And these are two really sad stories of situations where providers were using languages that they were not proficient in, that they did not speak fluently. These are true stories. The first one is a 3-year-old and a 5-year-old who presented to an emergency department. One of them had a broken clavicle, and the provider misunderstood when the family said se pegó, which means it got stuck or it got pulled, and they interpreted or they heard le pegó, which is more directive, like somebody inflicted this injury. And so these children were actually removed from their parents' custody by CPS as a result of the misunderstanding. And then once there was interpretation and there was more communication and understanding, that was reversed. But obviously a very traumatic event. The second story is an adolescent who was with some friends and he started to feel dizzy and had a headache kind of out of the blue. And he said, "Me siento intoxicado," and he lost consciousness. Some friends were with him and heard him say that, called 911. The ambulance arrived. The friends reported what he had said, and he was brought to the emergency department. When they arrived, they told the emergency department staff what he had said, and what the emergency department staff thought was that he had been drinking alcohol or doing drugs, and so there wasn't much intervention for him initially. When in fact he had said he feels that way, he had not been using alcohol or drugs. And it was about 48 hours when he had not woken up before there was head imaging that showed he had a devastating intracranial hemorrhage. So these are really terrible stories. There's a lawsuit associated with that second one in the hospital system. And I tell them because I think stories are really powerful and a powerful reminder of the risks of using languages where we are, there's no demonstrated proficiency or fluency testing. What about ad hoc interpreters? So sometimes families bring an aunt or a sibling with them because you're not sure they're going to get interpretation, or at least that's why I assume they might. And they want that family member to be their interpreter. Or maybe one parent wants to act as the interpreter for the other. Or maybe the patient is quite competent in English and prefers to speak in English, but the parents might not understand. And this is just a reminder, there are serious risks also with ad hoc interpreters of omission or misinterpretation. So in one study where they watched these visits and transcribed them and went through everything carefully, it was the majority of the time that there were errors with these types of ad hoc interpreters. And about a quarter of the time, there were clinical consequences with these errors. And when you're the provider in this situation, you don't hear the error. It's a risk, you don't know that what you're saying is not actually accurately being conveyed. I get asked sometimes about Google Translate. I think this came up earlier actually, and AI. We're not there yet, unfortunately, in this performing well for clinical encounters. So maybe if you're on vacation and you're wanting to ask about, something fun, food, something to do, and you want to translate to another language, you can use Google Translate. But for medical translation, it performs very poorly. So the majority of the time, it will be there will be problems with grammar or with content. In about half the time, that will be incorrect, misleading, or alarming situations. So some examples: your wife is stable, got translated as your wife cannot fall over. Your child will be born premature as your child is sleeping early. So nonsensical translation, and really should be avoided for any kind of medical communication. There's a lot of new phone apps which can translate different phrases into different languages and even say them out loud. And it might be nice for learning or working on your language proficiency. But the unfortunate thing about these is they're all one way. So unless you are speaking real time with a professional interpreter, you are not able to communicate back and forth. So you might be able to ask someone a question and say Mandarin, but you're not going to understand their response. That said, a lot of the professional interpretation vendors do have phone apps. So families or providers can have an app on their phone that calls up, as you can see in that photo, a professional interpreter who is live with you and interpreting what's being said. That's totally different than the static apps that just translate one phrase. Okay, so key points from this section, and then we're going to go through some challenging cases and some hopefully advice that may help real time and real life clinical encounters. So accurately identifying who needs an interpreter is really crucial, but it's also difficult. Language for care might be more accurate than limited English proficiency or even than language preference. And I think the key is that you need, wherever you are, to have a standard process to identify language and then make it visible. Because once we ask what the language is, if we don't make sure everyone on the care team is aware, then we're really not achieving the language justice that we're going for here. That patient and family is not going to get the interpretation that they need, and they're going to have to keep saying over and over that they might want a different language than English. So asking, identifying, and making it visible are really important. Professional interpretation still underutilized, and that's why we're all here, because we all want to improve that, and we still have a lot of work to do. Remember that it's the law, and that can help us when we're trying to advocate for this in whatever setting we're in. And remember that all modalities of professional interpretation can improve patient outcomes. And then remember the serious risks that are there with just quote unquote getting by without interpretation. So an informal or an uncertified interpreter, ad hoc interpreter, non-proficient language a clinician is using, or translation apps. So now we have some common scenarios which are challenging. And Casey came up with these because we get asked these questions a lot as we're talking about trying to improve interpretation in our clinical settings. And we thought they might be similar to ones that you've encountered. So I'm curious if anyone has any experience with this. Please let us know in the chat. Have you ever been in a situation where you thought that the family wanted an interpreter, and then you go in the room and they don't seem to be wanting an interpreter? They say, no, it's okay, we don't need it. So I'm seeing people are saying yes, all the above. What about different family members speaking different amounts of English and being unclear who you're supposed to talk to in what language? Sounds like that one is an issue also. And then what about if you have an interpreter, you've gotten your professional interpreter either in person or remotely, and you say something, say something, a really long phrase, and then what the interpreter says to the family is this short phrase that you don't speak the language, but you can't imagine that it's exactly what you had hoped would be said. Yeah. Okay, great. So I'm going to go through, and please feel free to share if you also have ideas of how to handle these. There are no clear right, and wrong answers here, but we can share from our experiences some ideas for you to consider. So interpreter refusal. So why are they refusing an interpreter? You've gone in the room, you're about to turn on your remote video interpreter, and the family's saying, no, don't worry about it. Or you went in the room and you said, I'm sorry, you want to speak Somali or Spanish, and let me go get the interpreter. And they say, no, don't worry about it. So one possible scenario is they just want to communicate in English. Another one is that they want to use a family member to interpret. I think I'll add a third here that I don't have on the slide, and that is they're worried it will take more time, or they might have to wait longer, or you will leave as the doctor or nurse and will not come back soon. And they just want to try and get by without it. So what do you do? First, check your biases. Who is asking or not asking for the interpreter, and what are your assumptions about what might be going on there? And try to understand, can you tell me why you wouldn't want an interpreter, and address that concern. Explain and normalize that medical language is complicated, and make it about your deficiency, not theirs. So I don't speak any of this language, and I want to make sure I'm communicating well. I want to make sure I explain everything well to you, and I want to use the right words. Is it okay if I just turn it on in case we need it, in case I can't explain something well enough? Is one potential way that you could address that. If they're asking you to use a family member, most places will have policies against ad hoc interpretation. And so you can actually rely on that and say, oh, it's our policy to use this video or to use our in-person interpreter. If you're comfortable with that, we'd love to have your family help make sure that we are communicating well and understanding. So those are just some ideas of how you might address those concerns. They can still refuse interpretation. So the clinician and patient characteristics here will influence the outcome of this discussion. And if they are continuing to refuse, then you will document that and move on. They do have to consent to interpretation. So there will be families who, even with your best efforts, do not want interpretation, and we will respect that. The caveat is that a minor child should never be used to interpret. So even if that's their preference.
Emily, can I jump in? There was a great and relevant question from the chat about what if the concern is about small communities, small language communities where everyone knows each other, and so concerns about confidentiality.
Sorry, I was just looking at the chat, and could you say that again, or could you answer it?
Oh, sure. Sure. Yeah, so it's not uncommon for people to be worried about confidentiality, especially if they come from a smaller language community. And so the most important thing is understanding why it is they're declining interpretation, because that allows you to try to problem solve. If it is a language for which there may be interpreters available via telephone or video from a national vendor, often those are drawing from a much larger group of individuals from across the country. And so you may be less likely to encounter a local individual who's part of their community. So that's often what I offer. And then also say, if you know the person, let me know and we'll just shut off the video, right? Or we'll just end the call. But that's typically the approach I've had the most luck with. I don't know if you have other thoughts about that, Emily.
No, I agree. I think that's a challenge with, I mean, especially when we're talking about language diversity and really, less common languages and, a lack of interpreter staff in those languages, it can be really challenging. This is great comments in the chat. Thank you everybody for your feedback, and I'm enjoying reading these, but we'll keep going here because we just got a couple more scenarios, these different degrees of comfort in English. So these examples of this that I encounter a lot, or a child or teenager actually prefers to speak English, a 14, 15-year-old, but the parent has another language for care. Or you have one parent who speaks English quite well, but the other is not saying anything, and you suspect maybe doesn't speak English as well. And maybe, one of those parents is the primary caregiver for this child and might be able to tell you, the most information about what's going on. So what do you do in these situations? I think the main thing to do here is try to avoid communicating only with the one who speaks English well. Certainly, especially if that is the patient minor child. But imagining that you've got two parents here, one who speaks English well and one who does not, you might just rely on the one who speaks English well, but the other one will be totally left out of the discussion. And if excluding them would not be appropriate in English, it's not appropriate in this language for care other than English either. And so the person who's speaking freely will be responsible to tell the other person what you said, and the other person will ask them what you said when you leave the room. And so trying to make sure that everything is interpreted, even if someone in the room speaks English, is the goal. And then the last one, concerning that the interpreter might not be interpreting everything. So like I had mentioned, the words don't seem to be equivalent to what you're saying, or it's a lot more than you've said, and you're not sure how your short statement was longer, or they're directly answering questions and you didn't hear the patient give a response. So those are some situations where you might you might question the sort of validity or how true the interpretations are. And of course, the language may take more or less time. And so you know, be careful here, because you might be wrong, it might be perfectly interpreted. But I think you trying to reframe your message and say it again, or using teach back can be great tools here to just make sure that in any language that your message is getting across. And make sure that when you're speaking through interpretation, that you're saying a short, clear, complete thought and pausing for the interpreter to then convey that to the family, to the patient. Enlist the interpreter as a partner. So tell them, I really want to make sure I'm hearing everything, even if they're just asking for clarification. So please help me by interpreting everything that's being said. And I recently got to be a part of a session on partnering with interpreters, and it was really cool to hear, you know, just how meaningful their work is, and how we have also a lot. We could usually do a lot better in really partnering with interpreters. So I really like that idea of like enlist the interpreter as a partner, because they also want what's best for the patient. And then direct feedback to them also. Okay. So any questions or comments in the chat for that section, and we'll have a little more time for questions. So you can also add those at the end, but I was going to just summarize here back to our objectives for this section and some key action items. So maybe I'll just go ahead and do that while people are entering questions about anything in our content, but as particularly about those challenging scenarios, feel free to enter in the Q&A or in the chat. So if we're going back to our objectives today and just reviewing some of the key actions, we wanted to critically evaluate your own communication practices, recognizing you may be contributing to disparities. And notice how your communication differs based on family characteristics and how that may contribute to disparities. Notice differences in how much or how often you communicate with families who have languages for care other than English. And if you are in a position where you can look at your patient outcomes and stratify them by race, ethnicity, language, insurance, and help identify these disparities, it will help you to seek them out and improve them. And then our second objective was to implement changes in how you communicate with families who use a language other than English for care. So use a professional interpreter every time you enter the room for families with LOE, and enter the room frequently and give them more time, because we know that we're at risk of missing something or under communicating. And it's a rare instance where we know what to do about this disparity. Try to give these families the same or even more opportunities to communicate, and take time to listen and wait as much as you can. Enact strategies to navigate challenging situations when communicating across languages. When patients refuse interpretation, frame the interpreter as something you need, and then explain the policy requiring them. If English proficiency varies in the room, have everything interpreted. And enlist the interpreter as your partner in providing excellent communication and patient care for families who speak other languages. Thank you very much. There are our emails. Either of us are very open to questions or collaboration. And there's a QR code there for an evaluation that's just specific to our institutions. And we would love to, I think, have about 10 minutes for questions.
Yes, thank you on that. So so many things that you covered and a lot of food for thought. We've been keeping up with the chat and interacting and addressing some of them. Couple that I want to pull up. One of the questions presented is there an opportunity on, interpreters giving social cues like less direct eye contact or give more time for the patient to think about answers, because sometimes you're witnessing some of those dynamics in the room, and that can be a challenge. Any nuggets of wisdom you can throw our way on that one?
Okay. Yeah, I mean, I think this is where the pre-session, both the pre-session and the debrief with an interpreter are key. So making sure you provide a little bit of context for the interpreter before you start your communication is an essential and often overlooked step to ensuring good promoting good communication during the encounter. And I think this is easiest to do with an in-person interpreter. You do it before you go in the room, but it's maybe more important to do with a telephone or video interpreter because they are just dropping into a clinical encounter. They don't know who's in the room. They don't know where they are. They don't know if they're in a clinic or a hospital or right. They could be anywhere. And so with telephone or video interpreters, if you can actually connect outside the room and give them a very short explanation of sort of what is about to happen and who you're going to be talking to and what the general content is going to be. I'm seeing a new baby and their family, and I'm just making daily rounds or whatever it is. That can really help. That can be done in the room too, if there's a video unit that's already in the room that you're using, for example. And then similarly, a debrief after the conversation, especially if it felt like things didn't go particularly well, keeping the interpreter on and just asking for feedback. Do you think there's anything that I missed about how communication was going? Are there things I should keep in mind the next time I talk with this family, right? And those can be done before or after. It's often easiest to do with an in-person interpreter, but that's absolutely where you can get some of those sort of social cues and tips for promoting good communication.
Awesome. So we have the questions keep rolling in. We have a question from Marcy. She wants to know, how are you all addressing shortages of in-person interpreters in your hospitals, especially considering the diversity in languages?
You want to take this, Emily, or me?
Sure. We actually have had a return of our in-person interpreters, at least in my setting. They were gone for a while, and then we were able to get them back after COVID. I know that's not the case in a lot of places. So I think, it's hard to speak without knowing all of the different options of clinical settings where you are, but it's a requirement that our institutions have some access to interpretation. So even if you don't think that there's access, there must be somewhere. And so talking with your leaders and advocating for making that more clear and more available, I think is in some cases probably all that you can do. But ideally, you have multiple modalities for interpretation because, we would love to have, concordant language providers all the time in every language, but we unfortunately can't do that. We would love to have in-person interpreters for all these languages, but that would be probably not feasible either. But when you've got those two options, plus you have video vendors, plus you have phone vendors, you start to really widen the net of languages that you can provide. And so I think the key is having as many modalities as you can, as much as you can, as easily and readily available as you can. And there's probably progress we can all make wherever we're at on that front.
Great, thank you.
Yeah, I will also mention there are national shortages of interpreters. And so I was in Philadelphia recently, and we were talking about it there as well. And so also something to think about, I know this is a big audience of people who probably work in all sorts of settings, but thinking about sort of pipelines and pathways to careers in medical interpreting, like there's actually a critical shortage that is influencing some of what, I think at our institution, a lot of times people think like, oh, we don't have enough in-person interpreters because the institution is not investing in it. But there are actually sort of structural constraints in that they've had open positions posted that they can't fill. And so then, it is telephone and video, even though those feel more limited, but making sure you're doing everything to optimize your access through those.
Perfect. Jen has a question. She talks about for our patients that speak an Indigenous language that may not have an interpreter readily available. That is, I will definitely say, an ongoing challenge here. We have started to discuss using picture communication to address some of their needs, like food choices and whatnot. Have you developed or used any tools like this for assisting when interpreters are not available for the language of choice or for nonverbal patients?
Yeah, that's a great question. We have a little bit of experience with that, although I think we're probably in a similar place where it's really can be challenging. I think about nonverbal patients, we definitely have like basic need pictures that we can, sort of use to, if they need to use the bathroom or wash or hungry, medications, we've done that certainly. For other nonverbal, I know we have used some pictorial communication for needs basically while they're in our clinical environment. I can't say that we've done as much with clinical communication. I don't know if you have any more thoughts about that, Casey.
No, I think the sort of key strategy for those less common languages, and this only works in some clinical settings, but is trying to schedule in advance when you know that there'll be a language need. And so when you're thinking about clinic, right, in the emergency department, it's just hard, right? And with an inpatient hospitalization, it may be really hard to get that interpreter on that first day. But if you know they're going to be there for a few days, you should be calling the vendor to try to set up an interpreter every day or twice a day, right? For that language, and ahead of time for as many days as you think they'll be there. And then similarly with clinic patients, right? Think about the systems to help set up that interpreter ahead of time for planned appointments. Again, same day appointments are really tricky, but if it's a well child check that you've known about for a month and a half, right? Can it flag the scheduler to actually set up that interpreter with the vendor 48 hours in advance? Because you're not going to be able to call and get your Mixteco Bajo interpreter immediately, but with 48 hours notice, you might, right? There are then going to be all of the challenges of are those interpreters, is the interpreter with the name of the language correct actually going to be understandable? And that's also where those like the fundamentals of good communication come into play, where you're watching really closely to figure out like, am I being understood? Is it getting through using teach back? And then really asking if it feels like things aren't going well and the family doesn't seem to be understanding well, asking the interpreter, are there things I can be doing differently? Or do you think you guys are understanding each other?
Perfect. A perfect segue. We're going to go into a break. The next couple of minutes. We'll be coming back at 2, but I want to say a couple of things first. Thank you both, Dr. Lyon and Dr. Hartford. This has been so informative and inspiring because there are ways in which we can innovate, connect, and meet our patients where they're at.